A very big hello to all my dear students. Welcome to the T2O series of your favorite channel, You and I with Ruchi. So today, let's discuss the recall question, okay, of INICT exam that you have just given. One or two questions are also confusing and controversial. So let's talk about it. First is, what is an isometropia? This was simple. We all know this. What is an isometropia? Difference between the refractive power of more than 2.5 diameters, right? So this is just a quick section. It's mainly a recall. So we all know that. What should be the answer here? Should it be difference in visual acuity? No. We all know when you talk about acuity, you're talking about sentence acuity by 6, right? Difference in refractive error between two eyes, difference in axial length, difference in size of eye. Little overlapping because everything here, this difference is also leading to difference of refractive error. But yes, no, the best option would be difference in refractive error between two. Okay, so this has all been dealt in your lectures and then videos. Yes, right? Come to the next one. A patient is presenting with vision problem in his right eye. On examination, IOP of his right eye is 50 millimeters of mercury, left eye 16. Slit line examination shows presence of flare in the anterior chamber and cataractus lens in the right eye. What is the diagnosis? Now, all of you, many of you are telling me that in my previous session, you all have told me that, okay, no, the increase of pressure has been mentioned in the other eye. So, with all logic, this is something I would consider as a miss. Okay? How is it possible logically that the problems are in one eye and the pressure is rising in the other? So let's forget it as some printing mistake. Maybe that has been a source of a lot of confusion for you all, and you are feeling a little unfair about it. But definitely, it's not logical to consider that way, right? And when we look at this, and yes, one of you had also told that the deep anterior chamber was mentioned, right? So if deep anterior chamber was mentioned in the question, then in that case, what should be the answer? The flare, inflammatory reaction in the aqueous anterior chamber. Best option is phacolytic. Why not phacomorphic? You will not have a deep anterior chamber there. You may not have flares there. The aqueous flare, which is, I don't know whether it was mentioned. Question, some people, but yes, let's take malignant glaucoma. Okay, one by one, a quick review of the options and why. Because I have to now further give your need PG. So malignant glaucoma, as you know, is also called celiac. And if you remember, reminding you, it is glaucoma after any intraocular surgery, which is due to, it is due to what? Helio-lenticular touch, right? What is happening? The aqueous is sequestered in the scalp. The aqueous is not flowing anteriorly, it is being collected in the vitreous cavity. That is pushing the lens iris diaphragm anteriorly, and when it is anteriorly pushed, that is leading to very shallow anterior chamber. Okay? So this is what a ciliary block glaucoma or malignant glaucoma. Why do you call it malignant? It doesn't respond to usual treatment. And how do we treat it? We are giving atropine, which dilates the very. So therefore, we also call it inverse. So we also call it here inverse glaucoma. You'll remember this? Right. Huge heterochromic cyclitis, of course, is a unilateral condition. It's an atypical anterior uveitis. You all know this, right? Again, the pressures cannot be like so high in this. Of course, it can lead to cataract, which is subcapsular cataracts. But looking at the whole thing, this fused heterochromic cyclitis doesn't seem to be a very convincing option compared to phacolytic. And I think some of you have told me that also that the age was also mentioned, and if the patient was of old age, if patient was of old age, again it goes more in favor of phacolytic than in favor of youth heterochromic. Okay? Youth heterochromic generally is a different story altogether. Okay? You all remember what about the features we learned in fused heterochromic? Difference of iris color, unilateral, delate KPs with feathery ends, right? And very minimal signs of anterior uveitis. The flare may not be seen at all in fused heterochrome. That's another point against fused. Okay, that's why we call it atypical. Because the typical features of anterior uveitis are what? Pain, redness, photophobia, discharge. Patient is not complaining of all that. There is no severe reaction. That is, and which one was the other atypical which you have read in your uveitis chapter? One is fused, and second, if you remember, was JRA, juvenile rheumatoid arthritis. Right, guys? So both of these conditions are presenting with atypical anterior. So that was about this. What is the last option I've discussed? We all remember phacomorphic. Intumescent cataract is causing a pupillary block. So when the lens is swelling so much that it causes block, that is what is your phacomorphic block. So naturally, where what we are answering here is phaco. Good. We come to the next. So this again, this you can see we are discussing here about the phacolytic. We come to the next, which of the following statement is incorrect about retinitis pigmentosa. So that's again a very important topic. Please revise it for your NEET PG as well. So retinitis pigmentosa, we all know there is which is incorrect. Okay, this is correct. Uh, Why? Because ERG will show diminished A and B both. So do you all remember ARG, A wave, B wave, and a very small C wave? A is corresponding to photoreceptor cells. B is B for B. B is bipolar cells. Your bipolar cells, and a very small activity, which is activity of retinal. Right. So in you must have seen it. You read this in advanced retinitis pigmentosa. You get a flat ERG. So ERG is of course, it's a dystrophy of rods and cones, and primarily they're affected. So that's also a correct statement. Late presentation is loss of peripheral vision. Again, this is why it is correct. Why it is correct, because initially in a typical RP, we have learned this. It's a mid periphery is what is involved, right? So mid periphery is involved, and later what happens? It progresses centrally and periphery. So peripheral vision will be affected a little late. What is wrong is night blindness is late. Night blindness, nyctalopia is an early, or the patient is presenting with this feature, right? So it's an early. Good. So once we are very clear, I think this question was never controversial. It's a very simple question. Learn your retinitis pigmentosa very well. A very quick few more questions like what is the most common systemic association of RP Usher syndrome, which is RP with deafness, right? Of course, then they have asked you about the typical triad, and as you can see, what is the triad of RP? Bony skews, attenuated arteries, pale waxy disc. And do you all remember pale waxy disc is what type of optic atrophy? The consecutive optic right. We come to the next. This next question, let's read it together. Patient of rheumatic heart disease who is non-compliant with treatment presents with complaints of superior field vision loss for past 1 week. What is the probable cause of the given? So if you look here, when you talk about a rheumatic heart disease, of course it can, all these four options are possible, right? But if it is asked to you about, if you see here, it is mentioned about a right, which is only at the superior field. That means a central vessel cannot be involved. The central vessel will not be involved. What is left? We are left with, is it a branch retinal artery occlusion or a vein? So artery occlusions are always very acute condition, right? Here it is one called, it's a scotoma which will take some time to develop. So the best option here that you will answer is branch retinal vein. Okay, so we will answer this as BRVO. Okay, so here you can see that BRVO normally is what it is most commonly, it is superior temporal retina which is called, but here because it's a superior field defect, it's inferior retina. And of course, you should revise for your NEET PG about CRAO and CRAO. Please do that. And what you see here is the splash sauce appearance of RVO. What was the other question on CRVO? If we are talking about splash source appearance, this 100-day glaucoma, right? Which is nothing but neovascular glaucoma occurring after 100 days. Come to the next question. Yeah. So this was again a little bit of confusing. Some people are saying it was written unilateral or bilateral, whatever it is. A 3 months old child presenting with photophobia and watering. If it's according to some of you, it was in one eye. Which of the following cannot be the cause? Now, when you talk about photophobia and watering, which of the following cannot be the cause? Right? So, if we look at all these options are going to lead to what is photophobia? Intolerance to light. How do you get it? When the sensory nerve, that is fifth nerve, is involved, correct? So photophobia will be happening whenever there is any corneal involvement or very severe conjunctivitis leading to some. This is the main reason, correct? So generally you see a very small child with watering. If you talk about watering, what can be the three main causes in a 3-month-old child? If you talk about the cause of watering, can be number one, of course, congenital dacryocystitis can be one cause of watering, right? Congenital glaucoma, very important. And the third one is your ophthalmia neonatal. So these are very important. This is the cause of watering in a very small child. This is the main DD that should come into your. So when it is saying it cannot be a cause, so this photophobia and watering will occur in dystichiasis. What is dystichiasis? You all remember? This extra fold of row of eyelashes. So this extra row of eyelashes are going to rub in the cornea and can lead to again watering and photophobia because it will rub on the cornea. Again, congenital glaucoma we all know presents with watering photophobia. Coming to and blepharospasm. Of course, photophobia will always go along with blepharospasm. Again, congenital entropion. Any entropion, inward turning of the lid, it is going to rub to the cornea. Again, it will lead to your photophobia watering. When you talk about congenital dacryocystitis, congenital dacryocystitis generally is not associated with photophobia because not the corneal involvement. Later on, if there's too much of infection and in later case, that's a different. But initially, it is only watering. So either we think in this way. If you're talking about unilateral and bilateral, I don't know how the question was framed, but yes, B, C, and D majority of the times are lateral, may be unilateral. It's always under the may be unilateral, but majority of the time it is bilateral. Of course, congenital dacryocystitis most common is unilateral. So I am because you all were not very sure about unilateral, bilateral. I've just given you the information. But what would be the best option? If these are the four options and I have to mark it, I don't have any other way but to mark this congenital deck. Hope it's clear. Because all three B, C, and D are majority of the time bilateral, but maybe unilateral. Yeah. So we have to look at the framing of the question, how it was. I think as of now, with this question, this which which also we have got only by exclusion. Because any chronic dacryocystitis, if it is too chronic, may involve cause a lot of infection and may cause even photo. But that is because it's the least chance we are marking it. Not totally clear of it. Chalo. Next we talk about is this patient is presenting with a tuna in his eyes and complains of irritability and lacrimation. What is any chemical in the eye? Any foreign body? First thing is always copious irrigation. Right? And therefore our answer has to be this irrigation with normal. And this copious irrigation should also be done with double eversion. Of course, you should revise and you should know that antibiotics, cycloplegics, what is the usual treatment? After the copious irrigation, what next? We give antibiotics, we give cycloplegics for the inflammation that it can cause. We also give steroids, but only for 7 days because after that it is going to hamper the healing. Steroids only for 7 days. Ascorbic acid and citrate also help in healing, and therefore this can be given in collagen synthesis. It will promote collagen synthesis. Okay. And then another thing, the very common question that is asked, this I think everybody must be knowing, which is more dangerous, acid or alkali? It's always alkali because it is penetrating the cornea and going inside and whereas when you talk about alkali, it just coagulates the protein and makes a layer in the cell. When you talk about acid, I'm sorry, that in acid burns, it is coagulating the protein and making a layer so that doesn't go deep inside. Right? We come to the next one. A 22-year-old patient with a high myopia and thick glasses and floaters. You all know floaters is what? Opacity is in the vitreous cavity. What comes in the mind first? We are talking about pathological myopia. Therefore, our answer should be what? You all know in pathological myopia, there's lattice degeneration, which can lead to finally hole formation and rhegmatogenous retinal. And these floaters, due to the retinal break, these floaters, which are too many floaters, which can be due to pigment dispersion, what do we call that? Schaffer's sign. We are talking about actually rhegmatogenous retinal detachment and Schaffer. So this will be the answer. Yeah. We come to the next question. All of our functions of superior oblique muscle except. No, when you talk about actions of muscles, be very, very thorough to you. I hope you remember how to learn the action of muscles. How did I teach? See, action of muscles, a very simple way to learn is divided into horizontal and for vertical. You have to learn two mnemonics is and rad. Is says superiors are in taut and rad says recti are adductors. So if we know this, what are superiors are intorters and recti are adductors. Horizontal muscle, I think, is life is easy. We have two muscles, lateral rectus, medial rectus. Lateral rectus, abduction, medial rectus, adduction. Correct? Then we have this is and rad superiors are in tortoise and recti adductors. Once we know this, now we are going to write a chart of the word. So superior rectus, inferior rectus, superior oblique, inferior. Now think with me. How to learn the action muscles? Tertiary, primary, tertiary. These are the three actions: primary, secondary, tertiary. So we have to keep in mind that because the main action of adduction, abduction are horizontal muscles, for the vertical, all these are tertiary. Because recti are adductors, we write here adduction, adduction, abduction. Okay? And then we all know superior rectus is elevation. Secondary action, superiors are in tortoise. So in inferior rectus is depression. They have asked you for superior. Primary action in torsion, superior, but it's oblique, so it's depression and abduction. They're all abductors, right? So here we will answer. What is the answer? Abduction. Except which one? Abduction. We come to the next. In a patient with oculomotor nerve palsy, which of the following action is not compromised? So, not compromised, very simple. We have to just learn about LR6 and rest are supplied, all the muscles supplied by third nerve. So, these are the two muscles which are not compromised. What is lateral rectus doing? Abduction. Superior oblique. Superior oblique is depressing, abducting. Intorsion, depression, adduction. Abduction. So, you know, intorsion, depression, abduction. See, what will be which in this patient with oculomotor nerve palsy, which of the following action is not compromised? This one is not compromised. Limited abduction, right? So this we will keep in. I think I have wrongly answered this. Very sorry. When you say all of the following are actions of superior oblique muscle after teaching, it should be adduction. No? Adduction is not an action. The rest all are except adduction. Now it's clear. So then we talk about what is the most common cause of proptosis in middle-aged person. What will you answer? Most common for proptosis ka cause. Just learn like this for adults, and for adults it is always whether we are talking about unilateral or bilateral, whether we are talking about painful or painless, whether we are talking about axial or non-axial. In all the cases, our answer is same. Is that this thyroid eye. And when we are talking about children, unilateral most common cause of proptosis, we will answer orbital cellulitis. Okay, and bilateral, suppose it is neuroblast. So we'll keep this in mind. Okay, then we come to patient presenting with LPS. So this was another question which has come to me. I don't know whether its exact framing is correct or not. LPS and Muller's muscle. LPS gone and Muller's gone muscle. तो LPS तो third nerve palsy हो गया. Muller's is sympathetic. Leg of thalamus is seventh nerve. Right? Decreased corneal sensation is fifth nerve. What is the most probable diagnosis? So what will you answer? If I look at the options, post-trachoma ophthalmia neonatorum, different story altogether. So our answer is leprosy. IME is also correct option. We will answer leprosy. And of course, we know in leprosy we get other features like thickening of the corneal nerves, decreased corneal sensation here. We have to keep, of course, there is itis and so keep all these things. Right, all of you? So we are going to take a very short break and start studying again. EG, we will not time, not a time. Relaxation. Just take a break of a day, another one day, but not more than. Okay, and then come back to your rapid fire mode. Keep on. Okay, thank you so much. Stay blessed. Keep